Okay, so again, we are pleased to have Dr. Marina Basina, a clinical professor of medicine in Division of Endocrinology with us. So she graduated from Moscow School of Medicine, completed her medicine residency at UCLA and West LA VA, and endocrinology fellowship at Stanford University. She serves as medical director of inpatient diabetes services, type 1 diabetes program, and a co-leader of enrichment core in Stanford Diabetes Research Center. Dr. Basina received numerous teaching awards, Master Teacher Award, and the Stanford Hospital Award for Excellence in Patient Care. And her primary interests are in type 1 diabetes, diabetes technology, and diabetes in pregnancy. And she's a co-investigator in several NIH-funded clinical trials, NIH Type 1 Diabetes, Acute Pancreatitis Consortium, and Type 1 Diabetes Exchange. She's an active member of Medical Advisory Board for Type 1 Community Organization. We are very pleased. Thank you so much, Dr. Basina, for your time and expertise. And we are pleased to hear your presentation. Thank you.
Thank you very much, Susan, and thank you to Center for Clinical Research here at Stanford organizing their series and inviting me to present this exciting and important topic today. And I'm going to share the slides. So I will introduce you and just go over, give you an overview of what are the advances in diabetes technology. It's really exciting time now because we are having lots and lots of innovations and a lot of advancements that have been done in the past, I would say 10 to 15 years, that we were not able to use for patient care previously. So we're very excited to be able to use this technology to improve patients' outcome, to improve patients' well-being, to try to reduce that diabetes burnout, and just to help our patients. So I will describe epidemiology of type 1 diabetes and state of diabetes control. We will talk about risks and benefits of tight glycemic control. We will review the history and evolution of glucose measuring devices as well as insulin delivery devices. We will discuss what closed loop means, artificial pancreas, and how does it work. And I'll show you some real-time, real-life data. And we will look into the future. So what are we looking at in the era of technology coming up? So first we'll talk about the epidemiology and the state of control. So about 1.6 million Americans are living with type 1 diabetes, including about 200,000 youth under age of 20 years old, and 1.4 million adults 20 and older. 64,000 people are diagnosed with type 1 diabetes in the United States only every single year. There is 5 million people in the US expected to be diagnosed by the year of 2050, including nearly 600,000 youth. So the diabetes type 1 is on the rise, and we're not 100% sure why is that. There are several theories why could that be happening, but we're seeing significant and persistent rise every single year. So the data from 2001 to 2009 showed that there was a 21% increase in the prevalence of type 1 diabetes in people under the age of 20. And I think the number is even higher actually in adults. In the United States, it's an expensive disease, unfortunately. As you know, the insulin is super expensive, all the devices are really expensive. So it's been calculated that about 16 billion in type 1 associated healthcare expenditures and income is spent annually for those individuals. So despite all these innovations and all the improvements that we are introducing, the data still about glycemic control is not that bright, unfortunately. So less than a third of patients with type 1 diabetes actually achieving target glycemic control. So target glycemic control, ideally we want to meet is to be less than 7%. And you can see that the category that we called emerging adults, which is the patients, including individuals from 13 to 25 years old, really have the worst control. And those are the individuals that we're looking, those are young people that we're looking at, 30, 40, 50 years, 60 years follow-up and complication developing from uncontrolled diabetes when they were at this age. So data back in from 2015 showed that estimated life expectancy loss in type 1 diabetes is up to 13 years. Granted, this data comes from 20 years prior data, which is including the data using not all of that innovation and technology as we're using now. But now it's hopefully less, but it's still a substantial amount of decrease in life expectancy. So for the stages of type 1 diabetes, there are 3 stages that are present. So the first stage is just when individuals will have autoimmunity. So they will have antibodies against beta cells of their pancreas that produce insulin. The blood sugars are normal. There are no symptoms, just those antibodies and multiple antibodies could be present. Stage 2, when people develop some prediabetes, which is defined as fasting glucose 100 to 125 or 2-hour postprandial glucose 140 to 199, or hemoglobin A1C, which is a 3-month measure of glycemic control between 5.7 and 6.4%. So there are no symptoms of low or high blood sugar during this period of time. And that's stage 3, when usually there is an acute presentation of diabetes with all the symptoms of high blood sugars, polyuria, polydipsia, and weight loss, and frequently admissions for diabetes ketoacidosis. So because of that, we're trying to do is to work on those 2 stages and see if we can possibly identify individuals who are at high risk and see if we can prevent them to go into stage 3. So for that, we have this Diabetes TrialNet organization, and Stanford is a part of it, that collecting the antibodies and following patients over time to see if we can enroll those patients in different research studies, trying to kind of abort this autoimmune destruction of the beta cells and not sending patients to stage 3 of the disease. So what we're talking about is that we are trying to keep control really tight, but it comes with its own risks. So we'll talk about what are the benefits and risks of this tight control. So the study that called Diabetes Control and Complication Trial that was run from 1983 to 1989, and the data was published. First study was published, part of the study was published in New England Journal back in the 90s. So this was a study including over 1,400 individuals who were young, fairly early in their type 1 diabetes, is only less than 6 years, and they were followed for 6.5 years. The patients were randomized to intensive group, which were kept at tight control with multiple daily injections or using insulin pumps or technology, whatever was available back then, or a conventional group, which was the group just to try to avoid symptoms of low and high blood sugars. So they were equally screened and randomized with hemoglobin A1C mean about 9.1 at the time of the enrollment. So as you can see at the end of the 6.5-year follow-up, the intensive group received, was able to get to hemoglobin A1C of 7.2%. Conventional group started with 9.1 and kept that the same number. So over the 6.5 years, this tight control reduced incidence of retinopathy by 65%, eye disease, nephropathy, kidney involvement, 54%, and neurological system involvement by 60%. So the results were very, very remarkable. Subsequently, those patients were asked to continue participating in the trial and to try to just be in observational group and to see if we can look at the cardiovascular disease outcome data and see if with this tight control, we can possibly prevent cardiovascular disease. So interestingly that in a year after this intensive groups stopped following on the very kind of frequent basis, in a year, both groups got to the same hemoglobin A1C. Conventional group got better and intensive control got worse. So their A1C numbers were equal. So even with that, following up to 17 years later, the patients who were initially in the intensive group still had 42% reduction of heart attacks, strokes, or death from cardiovascular disease. Death were by 57%, and this was statistically significant. So again, results were remarkable, showing that even if patients are well controlled in the beginning, body that keeps this metabolic memory that allows years later still having reduction in risk of cardiovascular disease. This was actually a very, very first study that showed that we can prevent cardiovascular disease with tight control. Now, the study is still being followed. So it's been 35 years and patients are still being followed. So this is the data for eye disease, for retinopathy complication. So as you can see, that is the results are still quite remarkable. That for retinopathy progression, there's still 18 years follow-up, there's still significant reduction in the group who started with intensive control. So again, it's years later with even having equal control 7 years after the study, they were still under significant reduction of retinopathy. But if we look at the same thing, we can look at the cardiovascular disease outcomes, right? So we're looking at 25 years since the enrollment into the study, and we're seeing the same thing. As we go on, this difference, this percentage improvement goes down, but it still remains significant years and years later. So 20 years later, results are still significant, still reduction of cardiovascular disease. So the message to our patients, it's important to initiate that control and to try to control yourself soon after the diagnosis and not waiting till complications already occur. Now, tight control comes with its own cost, with its own risk, and that is the severe hypoglycemia or any hypoglycemia. And that's, unfortunately, risk is not trivial. So this is really significant. As we can see that both DCCT trial and EDIC trial, patients had significantly higher risk of all low blood sugar events, and including severe hypoglycemia events, so including the coma and seizures. The same thing you can see on this graphs, that in DCCT, severe hypoglycemia requiring assistance of someone who can help with the glucose normalization. The dark bar is the conventional control, the percentage of patients who had severe hypoglycemia and severe hypoglycemia with seizures, where I think it's actually the opposite. So this should be the intensive control and conventional control. So it was about 3 times higher in the glycemic control with the intensive control. So why is that? And what do we see with what is the kind of the hazard of this tight control with the hypoglycemia? This was a very interesting study looking at the hypoglycemia overnight and during the day in patients with tight control. So those individuals were placed on the continuous glucose monitoring device that was measuring their glucose every 5 minutes, and they were blinded. So they were not able to see the data from this device. At the same time, they were placed on continuous electrocardiogram monitoring. And the patients who had their own continuous glucose monitoring devices were allowed to use those so they can have alerts and alarms if they get low blood sugar. So there were significant slowing of the heart rate overnight. There was significant atrial ectopic beats during the day, and there were significant prolongation of the QT interval that can lead to deadly ventricular arrhythmia. And the sad part of it that out of those patients who were enrolled, 62% had nocturnal hypoglycemia, low blood sugars overnight. And even the patients who were wearing their own continuous glucose monitoring device, only 24% of those were actually waking up from those low blood sugar symptoms. So this is definitely a huge concern about this tight control. There is another scary syndrome that we know it described in the literature, with this really scary name that called dead in bed syndrome. So this was the syndrome that was described in individuals who are on insulin, more type 1 diabetes, who were found in the morning dead without any other precipitating events, being fine the night before. So the study looked at the incidence of that, and it's actually pretty high, so up to 14%. So that was the concern. And there were various pathophysiology explanation to that, but again, the prolonged QT interval and those ventricular arrhythmias, and then sudden death was the most common cause of the death in these individuals. So what we're trying to do is to try to create or to come up with all those devices, try to improve the life of these patients, because and again, the number of individuals going up, and what have we done over the years for that. So if you look at this picture, this is a very famous first glucometer that had only the weight for the battery for this device was 1.2 kilos. So it had to be plugged into the wall, and you couldn't really carry this with you. And this was the huge bottle with the test strips. The first Lancet device looked like that, and patients who remember that still now, there are quite a few individuals who remember that. They called it guillotine because you can see on the huge size of the needle, and imagine poking the finger with this huge device. Now we have all those meters that we reduce the drop of the blood glucose to be able to measure the glucose from 50 to 100 microliters to 0.3 to 0.6 microliters. So that's been amazing advancement. One of the most important advancement was the discovery of the continuous glucose monitoring devices. This has been an amazing technology improvement in care in those patients. So what is that? So this is the sensor, which is very, very magnified. And I'll show you what the real one looks like. And I'm sure some of you had seen it. So the real, if you can see that tiny little thing that's over here on this picture. But this is, again, very magnified and cut through the sensors, through the layers. So it measures glucose not in the blood, but in the interstitial fluid. And it has multiple layers. One of the layers is the actual enzyme that oxidizes, glucose oxidase, that oxidizes the glucose, sends the data to this, the median or the central layer, which is the actual measuring device, and then it sends it to the transmitter that's attached to the device. So all of that, as you can imagine, creates the delays, right? So there is a delay from glucose measuring from or entering from the blood into interstitial fluid for this reaction to happen, for the data to get transmitted to the actual transmitter and then to the receiver, which displays the data. So those are devices that are currently available. So this is the Dexcom G6. This is a small sensor with a transmitter that's worn on the body for 10 days. This is the inserter with only one of this orange button push with the insertion, and the wear is 10 days. So patients do not have to poke their fingers at all. They can just look at their phones, at their Apple Watch, at any smartwatch, and they can be seeing this, the data, not only the data, what the current blood sugar is, but if it's going up or down or staying stable. And they can share this data with up to 10 individuals. For example, if there is a child that going to school and family members, the parents would like to watch to make sure of what's going on with the blood sugars, they can see it on their phone and they can set up their alerts and alarms on their phone. So this is the real time shareable data. If your significant other is out of country, as long as they have Bluetooth and Wi-Fi, they can still give you the real-time data. So there are some obviously drawbacks of this because this little transmitter has to be changed every 3 months. It's pretty costly. There's a lot of medical waste. This huge inserter needs to, because it will have a needle inside, so it would need to go to some sort of sharp container. So the adhesive itself can create some skin reactions, and there's some people don't like wearing stuff on their bodies, so that bothers them and not fun. Plus, all those alerts and alarms sometimes gets annoying. They wake you up at night. So another version of this sensor is a Libre Freestyle made by Abbott. There are two versions, 14-day and Libre 2. So this one works for 14 days. It does not provide the real-time data. So this is the receiver or the reader that you actually have to like swipe or scan and get the data, again, with showing whether that's going up or down. No calibration needed. The sensor, this little circle on the body, keeps the data for 8 hours if patients do not scan for 8 hours. So we're losing some of the data for over 24 hours. Medtronic has their own proprietary Guardian 3 sensor. So this is the little transmitter and a little sensor. So it's a 7-day wear, again, measures every 5 minutes. You can see all the data on the phone and you can share with other people as well. It can be standalone or it can be used with the insulin pump. So the newer kind of kid on the block is the implantable sensor, which is the Eversense. So it gets inserted underneath the skin, no sutures needed. There are little steri strips that we put on top. It does require about 6 to 8 or 5 to 8 millimeter little skin cut with a scalpel. And then there is a transmitter that worn over that sensor. So this is a totally different technology. This is basically an LED light emission. So when this transmitter sends the light signal to the sensor underneath the skin, the data is showing on the device, whatever device you're using for the receiving device. It would be the phone or other Bluetooth enabled devices. So it's worn for 90 days, and 90 days later, patients have to come in. We have to do a little cut again, remove that old sensor, which looks like this, a little tiny thing, and then put the new one in. So some patients like it because, as we said, people may not even hear their alarms on the overnight. This transmitter would vibrate on the body, so they will be able to more like another security check to try to wake up the individual with vibration on the body. So sensor data is great, but it may be overwhelming, right? So patients get 288 readings per day, over 2,000 per week, 4,000 per 14 days, 8,000 per month. So how do we analyze this data and how not to get overwhelmed about it? For us, we love those devices because it shows us a lot more information. So if we have patient who comes in and gives us those red dots finger stick measurements, we're thinking, where does hemoglobin A1C of 8.0 coming from? Why is it elevated if the blood sugars are so great? It's because we're not seeing those spikes that come in between those blood sugar checks. So we do try to counsel CGM users, continuous glucose monitoring users, that you need to be educated about your diabetes. You need to be prepared to see the real data because it's overwhelming to see the real data. If you are reviewing the data, how do you make changes? You don't react on each single every 5-minute number and do something about it, because that can be dangerous. What tools can be used to analyze those resources? So we do not want it to be the source of frustration and anxiety, but we want it to be the source, the smiling face, to be useful tool and not anxiety provoking tool. So for a successful CGM user, obviously to the longer the more they use, the more they wear, the better the outcomes. Check the trends often, realize that there are some lags. We said lags in between the measurement of the glucose, the food lag, the sensor lag, the insulin action lag. And we tell patients, experiment. No one would be perfect. Don't expect when you put the sensor on, don't expect that your numbers will be perfect from that. We teach the patient that what are the reality of glycemic control. Only 50% of the time when you start the sensor may be in target. So don't, patients shouldn't be freaking out from seeing those numbers 202 going up and then doing something right away about it. What are the realistic target that we can set up for those individuals who would not saying that, oh, I need to be normal, I need to be 80. So that is not the case usually. And what are the target ranges that we can set up? So those devices are useful not only, again, seeing the number, but because they're showing us the trends. And we're telling patients, if you are seeing double arrow up, you're already going up by about 60 milligram per deciliter up within 30 minutes. So you may need to add some insulin when you're about to eat and you're seeing those 2 arrows up. On the other hand, we want to prevent the low blood sugars. If I'm about to eat and my blood sugar is 100 and I'm seeing double arrow down, I probably don't need to take my insulin right now. I need to eat first and then see what's happening with my numbers and then take the insulin. So it's a great tool, but again, we want that tool to be useful and not anxiety tool. So we are switching to a different measure that's called time in range rather than hemoglobin A1C. And we're getting this AGPs that called ambulatory glucose profile reports that gives us the green bar. What is the time in range? What is the percent time spent in low and high or very high over 250? And in this table, it's a correlation of this time in range with actual hemoglobin A1C that we're seeing. So those are some real examples when we see patients, we're trying to say, don't focus on individual numbers. Let's try to find out what is the pattern. Like in this lower part of the graph, there's not real pattern here. So we can say, let's just start from the scratch as we're starting new on the insulin because there not any pattern here. On this graph, on the upper graph, you can see the pattern. You can see low blood sugars with subsequent high blood sugars and then low again. So there's probably not taking insulin on time, then taking it later, when the blood sugar is already high, then going low again, and then creating this roller coaster. So that would be very helpful for us to show to the patients and try to counsel the patient on their actions, what they're doing. So what did we learn about the CGM? It's useful and it could be life-saving tool if it actually tells us or warns about the low blood sugar. And it should not be overwhelming with those data and alarms. It should be as a learning tool and having realistic expectations. And those are the patient experience when they're wearing this device. So they do feel safer. They do feel optimistic about avoiding their complications without significant low blood sugars. They're more motivated when seeing those numbers, and they're more confident that they can avoid low blood sugars. So now we're going to switch to the insulin delivery devices. And this picture of Dr. Kadesh could be one of the most pictures that are posted on all our slides. So if he would have charged, I think, 1 cent for this picture, he would have been a billionaire. So this is the first insulin pump, how it looked like. And the insulin delivery was actually intravenously. And then other systems where this size systems for the closed loop that was by a stator. I think we still have somewhere this machine in pediatrics. So those devices were really, really huge and large devices. And I'll show you the current one, but what is the principle of the insulin pump? So it's only short-acting insulin in the pump, and it delivers micro boluses or micro kind of trickling of the insulin every few minutes. And then patients-driven spikes for of this insulin or insulin delivery for the insulin boluses for meals. And we program this bolus settings by entering how many grams of carbs covered by 1 unit, how many points we can drop by using 1 unit of insulin, what the target glucose we want to set, and what is our insulin duration. So this is the real-time data from one of the patients. You can see this is a closed loop system. This is 670 Medtronic insulin pump. So the peach color on this upper graph is what was before starting the pump. And you can see how significant reduction and flattening of the line we can see with the using of the automated delivery. And those little pink bars are the small microboluses delivered by the pump every 3 to 5 minutes based on the sensor data. And in the orange bars, there are how many grams of carbohydrates patient is putting in to bolus their for meals. And you can see it's not perfect, obviously. We cannot get to 100%, but it's 76% in range comparing to 48% before starting the device. So this is another device that is Omnipod insulin pump that uses the tubeless pump without any tubing. So this is the pod that's taped to the body. This is great for patients who are very needle phobic because it's taped to the body, and then this is a controller device that wirelessly via Bluetooth sends the signal to the pod. So you tape it to the body, and then you would say start on the this PDM device or personal diabetes manager, and you hear the click, and the needle gets inserted underneath this tape, so you'd never see it. So it's very convenient for patients. They really like it. So again, it's this automatic cannula insertion. They are waterproof. Patients can swim with it, go to the shower, do any their physical activities. So this is another version of the pump, and it's tandem or T-Slim pump. It's a very slick, very nice device, similar, I would say, to maybe a little iPad or iPhone. It's all touch screen, very small, that delivers the boluses and basal. It also communicates with the Dexcom, and the data all displayed on the screen. So which is works as a closed loop as well. Now we don't only have those insulin pump smarts, we're also getting smart with the insulin pens. And those are Bluetooth enabled pens. There's this Bluetooth over here on the pen that transmits data to the app on the phone. And you can see over here, when the patient got himself or herself the insulin injection and how much active insulin is still in the body. I usually advise patients who want to stay on the injections to go on this pen because I'm sure you've all experienced if you take some kind of pill or injection or something that you were going to do, and then in 5 minutes you would think, gosh, I had this pill in my hand. Did I really swallow it, or what did I do with it? So the app can show you whether you actually gave yourself the injection or not, so which is super useful. So what are the closed loops that we have? So the one that I showed you before. So the components of the closed loop are the sensor itself, the measuring device, receiver, where it receives the data from the blood glucose measurement, Then it goes to the algorithm that has several different algorithm now available. So it analyzes the data. So it looks at where I'm now, where I'm going to be in 30 minutes, and what my previous experience with this, with various insulin delivery was, and it executes the command to the insulin pump to how much insulin to deliver. So very smart devices. So this is a kind of the roadmap for get to number 6, to the fully automated pump. That's where we want to be. So where are we now in this? We are here. So we do have several devices that administer basal insulin, that administer the boluses, but the boluses are announced by patients, and they have to enter their carbohydrates. So we're hoping that we will be moving over here soon. So what is the data with the wearing of those of the closed loop systems? So I'm just going to try to run you very quickly through that. So patients who were wearing automated delivery had twice or half of the hypoglycemia comparing to during the study, comparing to what they were before overnight. For the nighttime to be in target range. So there was a significant increase in the time spending in a good range, 70 to 180, comparing to before starting the study on the same patients. Again, significant improvement for the whole time, that day and night. And for the lowest day at night, half of the time spent in low blood sugars comparing to what it was before the study, which is really, really significant. So those are the studies those studies and the data that we have available right now. And I want to point towards the specific glycemic outcome. So there was 70% overall time and range spent in the 670 Medtronic crossover study. And there was 12% increase in spending in time and range comparing to control. And if you think about those percentage, so every 5% increase in time and range equals to about 1.5 hour being in control. So we're adding about anywhere from 2 to 3 hours for the patients being in control over 24 hours. And the same thing for adults and children. For the tandem, for this slim pump with the that has all the touch buttons. So there was 11% increase time in range, and there was 13% time in range in adult population and 11% in kids. And again, this is the data that I just showed you on one of the patients, but it's sort of a little bit on the larger size that you can see that this patient was in auto mode 90% of the time, and that led to almost doubling the time spent in range being on the automated delivery as shown in blue. And this is just magnified picture, what I had shown you before. So again, every little pink bar is the microbolus delivered by the pump. So you can see as glucose started going down, the pump delivery shuts off. As glucose started going up, the pump delivery goes up, right? So the same thing you can see on these pictures to prevent lows. So this patient was going low, but it was prevented from going low by stopping the insulin delivery. So this is this tandem pump. So it has different modes that can be used during sleep time, during exercise mode, and normal during the day. And you can see that on the screen, this red bar, this one delivery was suspended. One patient was going low, but didn't go low because of that. You can see that line was going low and then it stabilized and became flat because the insulin delivery was suspended. So where are we going? What are we expecting in the near future, hopefully? So we are working now, currently, we're doing this islet study. So this is the study including also the closed loop pancreas, but including 2 hormones in it. So that's the glucagon and the insulin. So we were part of the phase 1 trial, which was several years ago. And so because this new device that's called iLet is now available, and that's what we're using currently in the phase 3 trial, this is what we're using in the phase 1 trial. And I think some of the studies actually were done in former GCRC. This is how many devices patients were able to follow. Some of my patients who participated, they said when they first were placed on all of those devices, they were just sitting and afraid to move because something could fall off and something can go wrong. But now this device is available. There are two cartridges for space for this, one for insulin and one for the glucagon. So if blood sugars start going up, the glucagon part fires and gives a tiny dose of glucagon. If the sugars are going up, then the insulin goes in. So this data on the first several of the phase 1 and phase 2 of this trial, the mean glucose difference was 20, so compare or lower in the bionic pancreas and the dual hormonal pancreas. The mean time spent in hypoglycemia was significantly lower, and the hemoglobin A1C significant reduction was in, so patients who were able to achieve the goal of 7% were 92, comparing to 41% in the comparators. So that this is the new stuff that's coming out, and we're hoping actually this year. So it's not in the far future. We're hoping for the very near future to see those devices. This is a new tandem pump, and it's called Sports Pump. So you can see how small that is. It's about half of the size of the current tandem pump, which already small to begin with. And the Dexcom 7 is coming out hopefully by the end of this year. So it's going to be all in one device. It will be small and a little bit more accurate than the G6. This is the new Libre that's coming out, and you're comparing it with the low coin size. And this is a new device also that is available in some European countries, sensor, and it's all in one. Also, in the transmitter is actually rechargeable. So hopefully that would be approved in the US as well. So we're expecting at the end of this year, early next year. So after my talk, you probably got the idea that that type 1 diabetes is complex and it's always there. It never goes away. Blood sugar don't always go as we want or as we planned them, or something just completely does not make any sense. It's very difficult for people because it's a lot of self-management. We're seeing patients every 3 to 6 months, but they live with this condition 24/7. So it's a feeling of this responsibility 100% for what's going on with yourself. It's arguments about diabetes. It's what we call home police, and somebody will, spouse or children or parents would say, oh gosh, you cannot eat this cake. Your blood sugar is already going high. So that's being constantly judged and constantly being reminded. All the worries and fears about what I'm going to do. What if my insurance is going to be lost? And hypoglycemia risk. Do I need to give myself some insulin now, or am I actually going to be low? So hypoglycemia had been associated with some cognitive dysfunction and early signs of dementia in elderly individuals. Severe hypoglycemia damages cortex and hippocampus in the brain and can cause seizures and various arrhythmias, as we discussed previously. And it's just having those recurrent events does make patients feeling down, depressed, anxious. Weight gain is always the case because if blood sugar goes low, then you consume the sugar or the calories, which is obviously hard to lose weight if you're trying to do your tight glycemic control and avoiding hypoglycemia at the same time. So there's such a term as diabetes burnout. And it's this collection of feelings and behaviors that occur all and over again managing this diabetes. So all the psychological factors, burdens of this tight control, trying to avoid the hypoglycemia, dealing with us as healthcare providers, and mental capacity having to successfully manage various components of this condition. So we're hoping this coming in future too. So this is the cars that recognize the lows. So all those GPS systems that are built in the cars should be able to get the signal from the sensor. And there were those cars demonstrated at ADA before COVID, and the car wouldn't start if the blood sugar is low from CGM. So it had been shown that there were almost 20% higher crashes, car crashes in someone who has type 1 diabetes. The patients who are driving, they actually spend 3 to 4% of the time in low blood sugars and 10% of the time in high blood sugars. Low blood sugars correlated with erratic driving on the high speed highway. So this was actually the study when they put accelerator in the front of the car, and also in the windshield, and also in the inside the car, to measure all those activities. So there's more risky maneuvering and variability of pedal control in even moderate hyperglycemia. So even hyperglycemia contributes to that. So one driver almost blacked out when blood sugar went to less than 40. Patient was not aware of the problem, and the review of the DMV records showed that there were 3 car crashes during that study, and they were all in diabetes participants, and there were a total of 13 citations, and 85 were those in diabetes individuals comparing to individuals with non-diabetes. So it's a balance of tight control with avoidance of hypoglycemia, with prevention of complications. This is a full-time job. And what we usually try to tell patients, this is it's not a disease, it's just your full-time job, and you're your own CEO that you have to manage yourself. So if having the right attitude and having the right vision, and not trying to be overwhelmed with everything what's going on is very important. And sorry, I'm almost over time, but I have some time for questions if there are any questions.
Thank you. Thank you so much, Dr. Basina. Please, everyone, if you have any questions for this section of the presentation for Dr. Basina, by all means, you either unmute yourselves or put it in the chats. The next section of the presentation is going to be with Dr. Sun Kim about the obesity treatment. So please shoot your questions, and then I will move to presenting our next speaker. Thanks, Peg. Yes, it's really, really great to see all these advances in technology. So we have one question from Christopher here. I've been a type 1 diabetes for over 20 years and have experienced the changes in diabetes technology. I'm excited for what the future holds in diabetes technology. Thank you for the presentation, Dr. Basina. That was wonderful. We have comments rather than questions.
Yeah, thank you for your comments. It's definitely very exciting times, because every few months something new comes out, and we're hoping that probably by the end of this year, most of the devices that, or at least insulin infusion devices, will become as closed loop.
Wonderful. Thank you so much. Okay, so I will move, if you have no other question, I will move to presenting our next speaker. We are pleased to have Dr. Sun Kim here with us. She's the Associate Professor of Medicine at Stanford University Medical Center. She's a board-certified endocrinologist who specializes in the treatment of type 2 diabetes, polycystic ovarian syndrome, and obesity. She's particularly devoted to helping individuals change their lifestyles and achieve sustained improvements in their health. Dr. Kim also works closely with the reproductive endocrinology group to help women improve their health, lose weight, and maximize their chances for a successful pregnancy. Dr. Kim also conducts research to better understand risk factors for diabetes and to develop better treatments for diabetes. Thank you so much, Dr. Kim. We are very pleased to have you here, and we are looking forward to hear your presentation. Thank you.
Thanks, Susan, for that nice introduction. Can you hear me okay?
Yes, we hear you well,
Okay,
and we have your slides.
And you have the slides. Okay, so I'm going to be talking about new era in obesity management. And I want to give a shout out to our endocrine team that are on this call. And thanks for Dr. Marina Basina for always giving a great lecture. So these are my disclosures. And then, you know, saying something is in the new era is pretty lofty. I think we're obviously in a new era for diabetes technology, which I'm excited to be part of as well. The reason I'm calling this a new era, if you are not aware, obesity is recognized as a disease. And I know Dr. Basina mentioned maybe type 1 is not a disease, but a job, but it's important to recognize obesity as a disease to be able to offer our patients the resources that they need to help manage their weight. And obesity management has more options than that's ever been available. And today I'm going to be talking about some medical and surgical options and one brand new medication approved in June of 2021, and more are on the way, which is good news. And Susan, I wonder if you could put up the poll. I hate to make you guys work because I know if you're like our endocrine team, you're probably multitasking, trying to be in the Epic box, doing your research, and also trying to listen to this. But this poll, if you can take a little time to do it, I hope it's fun. It's just a way to gauge your interest and also, you know, starting knowledge. So Jen and Leah, I'm expecting you to fill this out. So I'm going to give you a little bit of time.
So everyone, please try to answer the questions on the poll. We will see the results and we will share the results, but it's anonymous. So please do not worry, it's completely anonymous.
I know you didn't think you had to work, right? No, I'm just kidding. I'm just going to give a little bit more time. Again, please don't feel stressed about this. I don't expect you to, know the answers, and that's the reason for this. And it is anonymous, as Susan said, in case you're worried. And I'm not going to call on you, Jen or Leah.
We have 68% participation, so
okay. So maybe
hopefully you will get more.
Yeah, I'm just I'll probably just end the poll because the purpose just is to see kind of general. So I'm going to end the poll now. And just like many of my patients, belly fat continues to be a strong interest. I'm not going to say a lot about that. You can ask me questions, but I will allude to it. And then we will get to the answers for some of these questions. And I'm just looking to see what you answered so that we can, okay. So I can see we have a savvy audience. So, when I'm talking about obesity, I'm not talking about perceptions of beauty, and I'm just putting it at the forefront because I wanted to make sure that we focus on obesity as a disease and its health consequences. But it's hard to ignore in society that it's often equated with beauty, especially for women. But I also think it's interesting how our perceptions of beauty evolve, and I think it's going to continue to evolve. But obviously, our perceptions of beauty also affect the treatments that are out there and potentially harms that it can do and the stigma that it can create for individuals living with obesity. So I'm going to start out defining obesity medically, talk about some etiologies of weight gain, talk about complications associated with obesity and some of our newer treatment options. So medically, obesity is defined as a condition characterized by excessive accumulation and storage of fat in the body. And as I mentioned, in 2013, the American Medical Association identified obesity as a disease. I'm sure you're all aware, we commonly use body mass index clinically and in research settings, and it's defined as weight in kilograms over height in meters squared. It's a surrogate gauge of degree of excessive fat. It's not perfect, but it does tend to associate with certain diseases, and it's easy to measure. And there are different categories based on body mass index. I mentioned this category here. Sometimes it's called normal weight, but there's problems with that, as I'll talk about. It's also sometimes referred to as healthy weight, but that's there's also a problem with that because not everyone in this category is healthy and not everyone outside of this category is unhealthy. But currently, as we define it, healthy is considered 18.5 to 24.9. Overweight starts at a body mass index of 25, and obesity is defined as a body mass index of 30 or greater. Again, it's not a perfect gauge of degree of obesity, but it is commonly used, and it does tend to associate with diseases associated with obesity. I also want to mention that in certain groups, the definitions are a little bit different, such as an Asian population, overweight is defined as starting at a body mass index of 23 and obese as 27 and greater. So this was one of the questions in the polling question. What percentage of the population fall within these categories? Currently in the United States, adults 20 years and over, approximately a quarter are in this quote unquote healthy category. That means 73% or more are either overweight or obese. I bring this up because a lot of my patients feel isolated, ashamed that they can't lose weight. And I often start off the conversation by saying that all of us struggle with weight in our society, not just in the United States, but all around the world. I'm sure in the news, you always hear about prevalence of obesity and future projections. This is just one of many studies projecting obesity in the future. So this is a map of the United States in 2010, 2020, 2030. I'm sure you guys have seen some version of this map, and the color coding refers to prevalence of obesity, and the darker you get, the darker blue, it's greater prevalence of obesity defined as a body mass index of 30 or greater. And by 2030, we'll have a greater portion of individuals in this obese category and less in this quote unquote healthy category. What causes weight gain? This is also a common question I get from my patients. And it's, of course, not one answer. Some studies suggest that up to 70% of your body mass index is governed by your genetics, but genetics takes a lot of cues and works with our environment. And that can include modern lifestyle, other environment settings that I'm going to talk about. And of course, I'm an endocrinologist, so a lot of patients look to us to look for hormonal causes. And the two probably predominant ones that we check for are decrease in your thyroid hormone production and overproduction of a hormone called cortisol. But I would say for all the patients that I see, these tend to not be the major reasons for excess weight gain. So interestingly, or maybe sobering or depressing, all of us start to gain weight in adulthood, and some estimates suggest that the average weight gain is 1 to 2 pounds per year starting from your 20s. So 1 to 2 pounds per year. So you can do the math by, midlife, how much weight that can accumulate to. Not everyone, of course, gains as much weight, and some people gain more. A common question I get from women is, what are the effects of menopause on weight gain? A lot of things happen during menopause, but based on really good studies, there is not this massive increase in weight during menopause. But for both men and women, there is just the subtle increase in weight through the years leading up to 50, around the time of menopause for women. So I was talking about genetics and the environment. There's always an intersection between your genes and what was passed down to you and our ever evolving environment to create the phenotype, or the body mass index in this case. And the environment is actually really broad. It can start from when you were a fetus in your mother's womb, so the intrauterine environment. A lot of research in this arena to determine how early environment affects your phenotype, or your weight, or your excess weight gain later on in life. Of course, nutrition and physical activity are very important. Your medications, even your socioeconomic status. There are a lot of research going on, are things called endocrine disruptors, things in the environment that affect our hormone status. There's also tremendous interest, especially at Stanford, looking at the gut microbiome. These are bacteria that live with us, millions of bacteria that may affect disease and even your weight. Now, I was mentioning how, through adulthood, you may gain an average of 1 to 2 pounds per year. Well, there's been some studies during shelter in place suggesting that adults were gaining 1 to 2 pounds a month during shelter in place. However, I do also have patients who lost weight during shelter in place. So the environment affects us differently, and it's very individual. So this is a hard slide to see, but I wanted to share with you that we're learning about more and more complications associated with weight gain and obesity. One strong association, and something I work on closely, is the effects of weight gain and obesity on risk for type 2 diabetes. However, there's been research done to suggest that obesity may affect many of your organs, from your brain to your heart, your kidneys. Lots of active research here going on about effects of excess weight gain on liver disease, something called fatty liver disease. And of course, I can't ignore the fact that obesity has also been associated with severity of COVID-19 infection. I want to show you one study, one of many, looking at the association between obesity and severity of COVID-19 infection. So here on the x-axis is body mass index, which we've been talking about. And you can see that it's not perfect, but there is an increase in hospitalization associated with COVID-19 as body mass index increases, increase in ICU admission, increase in mechanical ventilation associated with COVID-19 infection, and maybe even some subtle increase in death associated with COVID-19 infection. As I discussed, probably the research started out and continues to go on related to what is the effect of obesity on risk for type 2 diabetes. These are older studies, but they illustrate that in both women and men, these were population studies that looked at starting body mass index and then followed women and men in time, 5 to 15 years, to see the risk for type 2 diabetes. And depending on your starting body mass index, over time, the risk for type 2 diabetes increased as the body mass index increased. This is sort of my last United States slide, but another slide to illustrate how closely obesity and diabetes are tied together. Some people call them the twin epidemic. So again, the United States slide, and they're color coded so that the darker the state, the greater the prevalence of either obesity, defined as body mass index of 30 or greater, or diabetes. And remember, majority of diabetes is type 2 diabetes versus type 1 that Dr. Basina discussed. And this is in time from 1994 to 2000 to 2015. And you can just see at first blush that, you know, the states have gotten redder. Of course, this always leads to political commentary, and I can't see if you're laughing or not, or you've heard this joke too many times, but I can't not make that joke. But to make the point that prevalence of obesity has increased, as well as prevalence of diabetes. For diabetes, this yellow refers to prevalence less than 4.5%, but I would say most of the states are now at a prevalence of diabetes, mostly type 2 diabetes, of 9% or greater. So this is just illustrating kind of the trend for both obesity and diabetes in the United States and really around the world. So what is the health effect of weight gain? And this is just a cartoon to illustrate where your fat lies in your body. Maybe you don't want to see this, but this is just a very simplified cartoon illustration that most of your fat actually lies right beneath your skin. And I know the instinct is to say, I don't want fat, but having fat is very important as a storage for calories in times of fast and famine, and it lies between your skin and your muscle, called the subcutaneous fat. You can look at it in another imaging. The fat is, again, right underneath the skin, and you know, we have a great surface area of skin, so we could potentially have a great storage of fat. So don't hate fat, but if you think about it as an energy store, it's very important. And I borrowed this slide from a textbook. And if you think about it as a tub of water, we need this water, and it gives us an energy store for our basic needs. And so we draw upon this energy store for basic metabolic rate. We also draw upon this for our physical exertion. There are other uses for this energy store. There's something that's a fancy term called non-exercise activity thermogenesis. This can include fidgeting through the day. So we draw upon this energy source, and we can build on this energy source through eating. But what if the faucet, the eating, overwhelms the capacity to store this fat? Obviously, this is a very dramatic example, but if you expand your fat capacity, you can also have storage of fat in places that you may not want in a lot of your organs, in your muscle, in your heart, in your kidney, in your liver, in your intra-abdominal area. And I think this is the genesis of the interest in belly fat, to have excess fat in an area called the visceral adipose tissue, but you also have sub-Q fat right underneath your skin in your abdominal area. This expanded ectopic fat can lead to a host of changes in your body. Sometimes we used to think of fat as being very inert, but it's very metabolically active. And it can affect degree of insulin resistance in the body, which affects many diseases associated with excess weight gain. It can lead to low-grade inflammation in the body, and then eventually in some of your organs, end-stage organ damage or fibrosis. Now, I want to switch gears to solutions. Almost every topic that I introduce could be a lecture onto themselves. So if you have questions, I suggest you put them in the chat, but I know that you guys are not super like question heavy people, but I encourage you, if questions come up, to put them in the chat. So tried and true is lifestyle changes. I really think that's foundational for any weight loss journey you're going to embark on. But I do want to touch on medications and weight loss surgery, which you may not hear as much. And then for lifestyle changes, I'm not doing this justice, especially to our endocrine team who spends a lot of time with patients counseling individuals on lifestyle changes, and they're so great and helpful to us. But I'm going to just give you key points, maybe takeaways from this lecture. And for eating patterns and plans, there's probably a new diet that's discussed on the web every week, and I hear about them from my patients all the time. However, the things that people agree on is, I think, what you should focus on, and they can make a great change. One key message is to try to increase non-starchy vegetables, and I often tell my patients to try to eat 3 different types of non-starchy vegetables a day. And another message is limiting added sugars and refined grains. I think this also has a big ticket item to your health. Added sugars are everywhere, and they're usually on nutrition labels. If you look at, a can of regular soda, you can expend what you need to intake for your whole day by just 1 can of soda. And then refined grains are grains that have been stripped of their nutrients. So examples could be white rice, white bread, limiting those. And if you need to substituting them for whole grains are something that I think most nutrition experts agree on. And then current recommendations for exercise is about 150 minutes of moderate intensity exercise per week. And you can break that down into 30 minutes 5 days a week. And I don't have time to go over your life plan, but of course, there are other things in your life that greatly affect your lifestyle changes, such as sleep and stress management. I just want to hone in on that key dietary advice. This is dietary intake in the United States based on current recommendations, especially for vegetables and fruit. And this line shows us people who are meeting recommendations, and then you can be above or below current recommendations. So for total vegetable intake, we're not doing that great with maybe 10% meeting current total vegetable intake recommendations. We're not doing great for fruit either, with about 20% meeting fruit recommendations. I always tell patients, again, the 3 different vegetables and 2 fruits a day. Also, the areas that we're doing really great are refined grains, which I said we should limit. And 90% or more of us eat more than recommended for that, and not enough whole grains. So if you can take a couple messages from this lecture, try to eat more vegetables. And now there are nutritional approaches that you can take if you're embarking on a weight loss journey, and there's many, and I wouldn't say that there's one clear winner. And if you have questions, please ask in the chat. I get a lot of questions about intermittent fasting. I would say if there was one diet that many people point to as sort of an overall diet, it would be the Mediterranean diet, maybe DASH diet. That's been proven in research to help lower your blood pressure. Let's switch gears to weight loss medications. This was one of the questions on the polls. There's actually currently 5 medications approved for long-term management of weight. Oops. One is called Orlistat. It's been around for a long time. It is available over the counter in a brand name called Ally, or as a prescription called Xenical, and it blocks the absorption of fat intake, about 1/3 of the fat you intake. The remainder, the 4 here, all work to reduce appetite. So all of these medications work to reduce appetite centrally. And there's 2 of them that are combination drugs, phentermine topiramate one, bupropion and naltrexone is another, and those are both oral medications. The 2 here, liraglutide and semaglutide, are injection medications, and I'm going to be talking about them a little bit more in detail in a little bit. But they were both approved first as a treatment for diabetes, and then they got approved for weight loss as well. And semaglutide, the brand name Wegovy, was just approved in June. And I'm going to spend more time talking about this. There are medications approved for more short-term. I tend to use phentermine quite frequently because it tends to be the most economical. One push to make obesity a disease is to allow insurance companies to be able to cover some of these medications for patients. There's a device that was also approved in 2019. It's more like a pill, but was approved as a device called Plenty. You take this with water and it sort of fills up in your stomach to make you feel fuller. I'm not going to be talking about that much today. What are the indications for weight loss medications? Again, we use body mass index. It's either 30 or greater, or 27 with comorbidities associated with weight, such as type 2 diabetes, high blood pressure, high cholesterol. I'm going to say a little bit about surgery as well. There are two main types of surgeries that are done for weight loss. One is called Roux-en-Y bypass, sometimes just referred to as gastric bypass, and sleeve gastrectomy. So if you think about your normal stomach and the upper intestine in gastric bypass or Roux-en-Y gastric bypass, you make the stomach smaller. I've been told that it's the size of an egg or a golf ball. And then you attach your distal small intestine to this small portion, and you essentially bypass your native stomach and the upper intestine. So the stomach portion is smaller, but you also bypass some of your absorptive capacity. In sleeve gastrectomy, you just make the stomach smaller, but there is no bypass of your intestine. What are the indications for weight loss surgery? Again, we use body mass index of 40 or greater, or 35 with same comorbidities associated with weight, such as type 2 diabetes. There has been a push to make this cut point lower to make surgery available for individuals at an earlier time on their journey, especially if you have diabetes or something called metabolic syndrome, which is a cluster of abnormalities that include increase in glucose, blood pressure, triglyceride, and low HDL. However, I think insurance has not been quick to cover surgery for people in this category. So if you've seen some of my talks, I love talking about this because I think it's so important. And I always ask patients when they come to see me, how much weight do you want to lose? So if you have ever embarked on a weight loss journey, in your head, how much weight would you want to lose to make you happy? And then this is an older study, and a majority of individuals, in order to be happy with their weight loss, wanted to lose at least 31% of their weight. So if you weighed 218 pounds, you wanted to get to about 150. And they would actually be disappointed if they lost 17% of their weight, which is about 180. I always tell patients my goal starting off is 10% weight loss. So it'd be 21 pounds. But based on this study, individuals would be disappointed with that degree of weight loss. What is weight loss that you should expect from some of the therapies that I mentioned? For medications, it has traditionally been 5 to 10%. And I think a lot of you chose this, but it's not unexpected to think that medicine should provide greater degree of weight loss. So people are often surprised that it's only 5 to 10%. And then surgery is generally associated with 25 to 30% weight loss. And gastric bypass tends to have greater degree of weight loss. So you can see there's sort of this gap in treatment outcomes from currently available therapies from 5 to 10% to 25 to 30%. Now, how much weight do you actually need to lose to have a health benefit? So that's another question we often get. And if you ask most providers, I think people will say any weight loss is helpful, which I also think is true. But if you wanted hard facts, I would say up to 5% definitely has an impact on your blood sugar levels, your triglyceride levels, and your blood pressure. If you have other diseases, let's say non-alcoholic steatohepatitis, which is a more severe form of fatty liver disease proven by biopsy, you may need 10% or more weight loss. Things like sleep apnea, arthritis. So if you have pain from arthritis and your provider has asked you to lose weight, I recently saw some data that 1 extra pound feels like 4 pounds for your joints. So losing weight actually has a great impact on the pain. It may not completely, it doesn't regenerate your cartilage, but it can alleviate the pain. And then for bigger ticket items, such as decreasing early death, you may need to lose 15% or more weight. And then CRP is a surrogate of inflammation. Remember, I was discussing that the extra fat and ectopic fat can lead to low-grade inflammation in your body. To have a significant change in that arena, you may have to lose more weight. What's the actual data for the medications that I mentioned? So these are 4 of the medications I discussed, and weight loss at 1 year. The salmon color refers to drug. The yellow refers to placebo. And you can see at 1 year, if you're taking any one of these drugs, you're expected to lose more weight than placebo, which is good. And that's why these medications were approved. But it's about, anywhere from 5 to 10%. I was really excited to have this new medication, semaglutide, come to market, because you can see this drug on average leads to 15%. So it's really sort of the, I don't know if game changer is the right word, but really gives us hope for future therapies for weight loss. So it's clearly the winner. And okay, I have no investment in this drug, except that I'm excited that it exists as an option for my patients. But it's a clear winner compared to what's currently available. And then because it's so impressive, I want to tell you a little bit about these class of medications. So semaglutide, as well as liraglutide, which is also approved for weight loss, mimic a protein made in your body called GLP-1, glucagon-like peptide 1. Glucagon-like peptide 1 is secreted from your intestines after you eat from cells called the L cells, and it increases in response to food intake. And it was first developed for diabetes because it was shown to increase insulin secretion and also decrease another hormone called glucagon, which can both help to lower blood sugar. So again, both of these medications are approved for treatment of diabetes, but what was also recognized was that it helped individuals lose weight. One of the main mechanisms is it decreases appetite centrally in your brain, but it also slows gastric emptying, so you feel fuller. And the new medicine semaglutide, it is approved at a higher dose than it is approved for diabetes, as well as liraglutide. And we've done some research showing that the higher sort of the activity of GLP-1 in your blood, the greater the degree of weight loss. There are, of course, side effects. I always tell my patients there's kind of no free lunch with anything, but the most common side effects are nausea. Some people get diarrhea and some people get constipation. And then the gut hormones that exist, again, I mentioned GLP-1 that have been associated with decreasing weight. But in the future, you're going to see a lot more gut hormones being used to manipulate weight and decrease appetite. Recently, there were some really exciting studies with a dual agonist, meaning it affects receptors at GLP-1, but also binds to GIP-1 receptors. This is another gut hormone called glucose-dependent insulin-tropic polypeptide, which also increases after eating and also can help increase insulin secretion. But there's a dual agonist that has shown some really promising phase 3 studies to help control blood sugar as well as weight. somewhat equivalent to that new drug semaglutide. So I'm excited to see this come out in the future. There's, it's funny, but the term, so I don't know if I mentioned it, these drugs are sometimes called incretins because they're made from your gut after eating. And so the dual agonist is sometimes referred to as a twin cretin, but there's also potentially a triple agonist coming out in the future as well, including another hormone called glucagon. So I think this is something to watch out for in the future. So I'm excited to have more therapies to help individuals on their weight loss journey. I'm going to end with something that people don't tend to talk about as much, is weight regain. If you've ever tried to lose weight, you know it's hard. It's so hard. And I get super excited when people lose weight, but maintaining that weight loss is also a very active process. So this is one study showing years after weight loss. So, and this is a percentage of lost weight regained. So if you do nothing after you lose weight, you may regain 25% of the weight that you lost in the first year. And then by 5 years, you may regain most of the weight that you lost. And so that tends to be true with medical weight loss. So maintaining the weight that you lost is a very active process. Even with surgery, there's variability after you lose that 25, to 35% of your initial weight. This is one study after gastric bypass. So at 6 months, people lost, the 25 to 30% weight. And then there are different groups. Some people regain weight, not that many, but some regain weight. Some stabilize, and some even lose more weight. So one of the common things that my patients tell me when I bring up surgical weight loss as an option, they'll say, oh, I know someone who regained all their weight back and I don't want to do that. Well, that definitely can happen. And even maintaining the weight after surgery is an active process. I'm going to leave you with sort of one last study honing in on this topic. Is a recent study that came out looking at how best to help patients maintain their weight. And another question I often get is, can I stop my weight loss medicine, after I've achieved my target weight? So this may answer that question. So what they did in this study is they took individuals who were successful at losing weight, at least 5% of their baseline weight. So this was, some of these patients lost more. So this was about, 13 kilogram loss. Remember, kilogram, you have to multiply by 2.2 to get pounds. So a lot of weight was lost before the study, and they only took people who were successful at losing weight. And then there were 4 arms to the study. So after you lose this weight, let's say you do nothing, which is the placebo, you then can incorporate exercise. And so exercise was defined as 150 minutes of moderate intensity or 75 minutes of vigorous intensity exercise. You can also have patients start liraglutide, one of the medication options, at and the dose, if you're interested, was the 3 milligrams per day, or you could do both exercise and liraglutide. You can see that if you do nothing, you are going to regain some of that weight. And at 52 weeks or at year, it was about 25% or more weight regain. If you committed to exercise, this 150 minutes moderate intensity or 75 minutes of vigorous intensity, you can maintain the weight that you lost. That might also be true with the medication liraglutide. But if you did both, you actually lost even more weight. So again, honing in on this idea that weight maintenance is an active process. So this is my, I see there's a lot in the chat, but I'm not sure if there are questions, but for the conclusion, I want to leave you with the thought that obesity is currently recognized as a disease, not a stigma, with treatment options. Obesity is a complex interplay of genetics and our constantly evolving environment. There are 5 medications now for long-term management of obesity and to help individuals on their weight loss journey. More are on their way, and weight maintenance is an active process. Okay, thanks for your time.
Thank you so much. Really appreciate it, Dr. Kim. We have one question, I believe, in the chat.
Okay, sure.
For type 1 diabetes, does insulin increase fat storage in the location of injection?
Okay, so that is also a common question we get. And I want to back up a little bit by saying that traditionally we used to define type 1 and type 2 diabetes a little bit differently. And people always assumed, you know, type 2 is associated with being overweight and type 1 being leaner. But now, you know, gaining weight for individuals with type 1 has become an issue, just like for the rest of the population. And one of the questions we get is it insulin? So insulin is critical for patients with type 1, but insulin can be associated with weight, not for what you think about it promoting fat deposition, but use of insulin, you know, obviously Dr. Basina mentioned, you know, we're constantly working to tailor the algorithm for how much insulin we give, but we can always give too much and leading to hypoglycemia and leading to, you know, individuals being forced to eat. And there may be also a hunger aspect to insulin. So a lot of times we do try to use some of these therapies that we use for type 2 as adjuvant therapies for individuals with type 1 to help with the weight and the appetite as well. But I want to leave you with saying that I don't think necessarily insulin is the villain, because it's critical for the therapy, but it does make, you know, losing weight challenging.
Wonderful, thank you. There is another question from Tanvi asking, I was wondering, why is Asian a different category, and scientifically who is included in that category of BMI? For instance, do South Asian folks stand in the same category as Southeast Asian?
So that's a great question, because, you know, I do a lot of work on Asians, but we lump them all together, but they're not all the same. Even for, you know, East Asians, there are differences. But I will tell you, for that body mass index, South Asian Indians are included in that lower, you know, body mass index. The reason for that is, you know, in population studies, we see the association with disease happening at an earlier body mass index. And also individuals who are of Asian descent generally have a different body frame and size. For instance, I work with large populations in South Korea, and we definitely see a lot of diseases associated with obesity, such as type 2 diabetes. But the range in BMI tends to be not as high as in Caucasians, but that these diseases start at a lower BMI. But doesn't mean that necessarily like the effects of weight are happening earlier for Asians. It's just, I think, a difference in the population body size. And again, body mass index is a gauge of excess fat, and we're not actually measuring fat. So there's a lot of studies looking at that in, you know, different populations to determine what's really affecting the association with diseases.
Thank you. Dr. Basina, by all means, you have a comment about the previous question that it causes some fat cells growth at the site of injection. So if you would like to
so it is true. The way that I think I interpret the question that you had was a little bit different, but Dr. Basina is mentioning that in individuals who do a lot of injections with insulin therapy, there can be hypertrophy of the fat at that local site. But that's also very individual and different. It doesn't happen with all patients, but some patients get them to a greater extent. Oh, okay. So someone asked, thank you for all these great questions. And yeah, someone asked about the gut microbiome. So, so interesting and a lot of research going on, but it's so hard to do research with gut microbiome. So I don't know if you guys know Justin Sonnenberg's work, but it takes months. We're actually waiting for some data analysis comparing Mediterranean diet to ketogenic diet and looking at the gut microbiome. But the analysis is very difficult because there's millions, I mean, they say trillions of bacteria in your gut. But what we do know is the gut profile seems different in individuals who are obese versus lean. So there's an interest is what came first. And can we manipulate the gut microbiome to have an impact on someone's weight? So there have been studies, definitely studies being done in rodents that suggest perhaps we can manipulate that. There have been some studies where they're getting stool from lean, healthy individuals, like drying them up and perhaps thinking about giving them to obese individuals to see if it has an impact. I would say that that's something you're going to see in the future. I hope it works, but I couldn't tell you that there's one formulation of probiotics that you should take right now that it's going to have an impact on, you know, on your weight, but that's what people are hoping to achieve. I think Christopher Gardner also had some studies about looking at different types of foods like kimchi and yogurt, and seeing some effects on the microbiome. So the food definitely changes your microbiome. I think your activity can also change your microbiome, but whether if we can manipulate the microbiome to change the person is a question for the future.
Speaking of Dr. Sonnenberg and Dr. Christopher Gardner, we had both of them actually at our science series. Dr. Sonnenberg presented on gut microbiome in December, and Dr. Gardner presented about the science of nutrition in February, actually. So both of the recordings are available on our website. If any of you are interested, it's available for you to listen to. So again, if you have any other questions, please, Dr. Basina is also here, and Dr. Kim, both of them are available, and we have some time to answer any questions. Please unmute yourself or put them in the chats. So I have a question myself. You mentioned the most recent drug that has been approved, the
Semaglutide, Wegovy.
Semaglutide has some side effects, but are they temporary side effects, like at the beginning when they start taking them, or it's because it sounded very minor side effects like nausea and.
Oh, well, I would say in the studies, you know, most people were able to tolerate it, and we do a step-up therapy. So you start the dose low. There's 5 dosages, and you start low, and you take each dose for 4 weeks, and then you advance. But there's, you know, probably about, 10 to 20% people that it gets pretty miserable. I've been told that nausea and itching are the worst symptoms. There's probably other worse symptoms, but to have chronic nausea is a very uncomfortable feeling. But you can also get burping, but it's tolerable. And that's why we start with low dose and go up. I do know of physicians who actually tried high dose just to see if they could do it without ramping up, and they got pretty sick. So I don't recommend that. I would say there's a question about the medication that blocks fat intake, which I think you're referring to orlistat. What are the negative consequences? It's tolerable, and that's why it's also approved over the counter. However, the limiting side effects are flatulence, I'll say it out there, farting, leakage, because whenever you block absorption of food, you're going to get diarrhea. And then you can affect absorption of certain medications. So just be cautious of that. You may have a depletion of fat soluble vitamins because of the diarrhea. But I have patients who, if they have constipation, they, actually like taking the medications. So those are sort of the potential side effects, but not, severe downsides. Very rarely there were associations with liver disease at high doses in a very few people, which seemed idiosyncratic. And then, okay, so someone did ask,
comment,
so someone who exercises a lot wrote, no, I'm just kidding, Donna, but isn't 30 minutes of exercise a day not enough? Well, I would say a majority of adults don't get 30 minutes a day. So that's sort of what we found in certain studies to be kind of, I would say for you, adequate. And the study that I'm thinking about in my world is the diabetes prevention study, where they took individuals at high risk to develop diabetes. They had pre-diabetes, and one of the goals was 150 minutes of exercise per week and 7% weight loss. And that combined had a great impact on decreasing future risk for diabetes. And so I think from there, because we had evidence there, it became kind of the recommendation, and majority of people aren't even getting that degree of exercise. However, if you want to lose weight using exercise, I definitely recommend people to double that amount if they can. So there's no harm in doing more. I agree with you. And then if you want to use exercise for weight loss, you do need to do more. And then I heard from many people that behavior modification, Noom, is quite effective. So Noom, there are, I'm all for all, because, our staff in endocrine clinic is often overrun, because I think the dietitian consultation is so pivotal to patients, especially with diabetes, people on a weight loss journey. So I'm excited for all these online platforms helping individuals with weight loss, because it also, provides more opportunities for people. And Noom, I think, is a big player, but it has to resonate with someone. Like, even, Dr. Basina was mentioning all the tech and how wonderful it has been for patients. It's wonderful if you like to use it and you use it. So Noom can be overwhelming for some patients, but if you have the time for it, I think it's great.
Okay, any further questions or comments? Okay, I guess we can end it earlier. I'm going to give 10 minutes back in your day. Again, thank you so much, Dr. Kim and Dr. Basina, for your very informative presentation. Myself and my colleague here, Kira Davis, really appreciate your time. And thank you so much again for sharing your slides with us. It's a great reference for our participants to have for future. And we will also upload the recording to our website, available for everyone. And thank you so much, all the participants, for attending. As I mentioned, I will send out an evaluation, and please make sure you complete the evaluation. We always try to improve, and we would like your feedback. But if you also are trying to have the BRN credit, you need to make sure that you complete the evaluation and put your name in there. And just a little announcement, our next bi-monthly science series is gonna be on the topic of psychiatric first aid. It's gonna be presented by one of our fellows, Dr. Julio Nunes, and it's on October 6th. It's Wednesday, October 6th, from 9 to 11. We will send out the announcements sometime during next month. So Kira, if you don't have anything to add, I think we can send it here.
Yeah, no, I'm good. Thank you, Dr. Basina, Dr. Kim. Nice to see you both. Thank you for your willingness to participate. Great presentation. Have a good
Thank
day.
you.
Thank
Bye.
you.
Have a good day, everyone. Thanks. Bye.